Good evening, and welcome to the Miracle of Living presentation tonight. My name is Dr. Fred Dennis. Before I go any further, though, I wanted to make sure that I give a big shout out to Mary Ford. It's amazing the amount of work that goes into making something like this seem seamless. And we know that Mary does a great job, and I know that you're going to appreciate what's going on tonight. We have a couple of really top-notch physicians who are going to be talking about what's going on. I'm an emergency physician, so that means I know a lot about little things. And I've worked in many different emergency departments, but now I'm doing administrative, and I'm currently medical director of Torrance Memorial IPA. And in that role, I get a chance to see the work that our two guest speakers perform every day. I see their clinical records that they provide and the care they deliver to physicians and the level of excellence that they really exhibit on a daily basis, and also the complexity of what they're going to be talking about. First, a few housekeeping things. We're going to have roughly 20-minute presentations. We're going to ask you to submit questions, but the questions will hold until after the presentations so that we won't interrupt their train of thought and the flow. Just another housekeeping item, those of you who are present in the room, please make sure that your cell phones are turned off. Thank you. Before our speakers talk, though, I want to share just a little experience I had as a research assistant at Princess Margaret Cancer Hospital in Toronto, Canada, when I was in medical school. I was doing work on immunology at that time, and of course, there was almost nothing known about it. But one of my professors made a statement that stuck with me over all these years. He said that probably the biggest single evolutionary advance that humans had made in 500,000 years was the development of our immune system. And I have come to understand what that means. So kind of an educated layperson interpretation, each one of us is composed of about 30 trillion cells, trillion with a T. And each one of us is a carrier for about
Danny, how you make it louder?
8 trillion organisms in and on us. So things like bacteria, protozoans, viruses, etc. So we are an ecosystem of about 67 trillion organisms. And most of the time, all those organisms get along pretty well together, but sometimes they don't. So sometimes, for instance, you'll get a cut and the bacteria that live on your skin will then attack you, and then you have to fight them off. Sometimes the cells, when they're reproducing, because we're continually replacing the cells in our body, will not stop reproducing, they'll keep reproducing, and we'll have cancer. So the immune system essentially is the cop here. They're the traffic guard, they're the sheriff, they're the military. They make sure that all of our cells get along well together, which they do most of the time. But every once in a while, they don't. And then you get what's called autoimmune disease, where our immune system, which is supposed to protect us against these different types of aggression, then attacks itself. So that's my basic understanding. That's about as complicated as I can get. However, we're very lucky, as I said, to have two excellent speakers, very knowledgeable tonight, who are going to be able to explain in more detail. So were you going to go first? Okay. Well, so our first speaker tonight is going to be Dr. Dilrukshie Cooray. Both of our speakers are rheumatologists, and I'll ask them to explain what their definition of a rheumatologist is, because I always tend to simplify these things and think of a rheumatologist as somebody who specializes in inflammation, but it's way beyond that. She completed her residency, chief residency and fellowship training at Loma Linda University and was assistant professor of rheumatology at Harbor UCLA before she joined us at Torrance in 2013. And with both of our guests, I asked them to just give me a little bit of an idea of how they de-stress. So I'm going to get a little tangential for a second. Those of you that were at the last presentation know that I have a very strong interest in burnout, and physicians, I think, have been never more under the gun than they are right now. It's never been more difficult to practice medicine. And so I'm always fascinated by how high functioning individuals, especially physicians, can manage to lower their stress level and day by every day still be on point. So Dr. Cooray tells me that she loves playing tennis and swimming and gardening and hiking, but she's also into classical music and got back to playing classical guitar. Plus, she's also engaged with her book club. So that's a great balance. That's an opportunity to lower the stress level after a very difficult day in the office. So, Dr. Cooray.
All right. Good evening and welcome. We're delighted to be here with you this evening. Thank you to the organizing committee for the invitation to speak. And thank you to all of you for joining us. So before I begin, I just wanted to pay tribute to a phenomenal rheumatologist who just passed away in November of this year. He was just very much loved here in the South Bay. And so Dr. Stanley Tobias was a colleague, mentor, and dear friend. He was actually the one that recruited me here in 2013. I met him in 2006 when I was faculty at Harbor UCLA. And we'd been friends for many years, and he kept trying to convince me to come out into the community. So it took a couple of years, but finally in 2013, I decided, yes, I think that's the right thing to do. And I actually gave my very first Miracle of Living lecture here with him back in 2013. He was an ardent advocate of patient education and started the fibromyalgia lecture series in 2014, taught it all the way through till the beginning of the pandemic. And to this day, patients are so appreciative of everything they learned and really felt like it helped them with their quality of life. So we're grateful to Dr. Tobias for all of his many contributions to South Bay Rheumatology, and we will remember him. We miss him dearly. So the organizing committee asked us to discuss autoimmunity. So realize this is a very broad topic. And what we're hoping to do is I will lay the foundation of what autoimmunity is and perhaps give you a lens or perspective into some of the diseases we manage. By the way, Dr. Dennis, rheumatologists deal with autoimmune diseases. So there's over 100. We don't exclusively deal with all of them, but many of these come into our purview. So I'll show you a slide later on as to the types of patients that we may see in our clinic. Dr. Gamboa then will follow up with talking about 3 of our main diseases, and he'll delve a little bit more in depth. There's no way that we can cover the nuances of each and every disease, so please realize that. But we will do our best to at least give you an overview of autoimmunity. So without further ado, let's dive in. So what I hope to accomplish is to review the immune system. We'll talk about what autoimmunity is. We'll talk about risk factors, signs of possible immune system problems, how we go about making a diagnosis, some of the factors that come into play of making these diagnoses. We'll talk about overarching themes of treatment, and then we'll discuss lifestyle modification, nutrition, and fitness. So the organizing committee felt that these were good talking points, and we'll try to address these to the best of our ability. All right, so at a very fundamental level, let's talk about the immune system. It is separated into 2 arms, the innate and the adaptive immune system. So the innate immune system, if you think about it, is what we're born with, right? And so the physical barriers, the cough reflex, the skin, the tears, the mucosal layer, the stomach acids, babies are born with this. And then over time, we develop this very sophisticated immune system. And so you have the physical innate immune system. And then if a bacteria or pathogen is able to evade that, then the phagocytes, all those different cells are kind of the first line of defense. And so they try to engulf the bacteria, what have you. And if those fail, then the adaptive immune system kicks in and tries to take care of the invading pathogen. And at this level, antibodies are formed. And so that the next time the immune system sees this pathogen, it knows how to address it and it attacks it right away. So this is very simplified, but I kind of wanted to give you an overview of what the immune system is like before we discuss autoimmunity. So what is autoimmunity? Well, autoimmunity is failure of the body's immune system to recognize its own cells or tissue as self. So it thinks it's foreign and it starts attacking it. And so oftentimes the immune system is attacking healthy cells. Any organ is fair game in these autoimmune disorders. And sometimes in the same patient, you can see multiple organs involved, and as you'll come to see very shortly. There we go. So hopefully this cartoon may depict, sometimes a picture is worth 1,000 words, isn't it? So this may depict what happens in an autoimmune disorder. So you have a white blood cell there, one of those phagocytes that I showed you earlier on. It may encounter a bacteria and it identifies it by this antigen. It's kind of a marker, if you will. And so it attaches to this bacteria, produces antibodies and tries to kill it. That's what the immune system does. But then sometimes it becomes confused. Our healthy cells make antigens as well. And so in autoimmune disorders, these blood cells then are attacking healthy tissue. They're attaching to these antigens and creating antibodies against self. And so this can culminate in any organ being attacked: kidneys, skin, lungs, what have you. Any organ is fair game. So just to kind of keep things light, this cartoon kind of depicts that, our immune systems are betraying itself. This is what's happening. So what are the risk factors for autoimmune disease? Well, there are multiple. Genetics is thought to play a very big role. Infections, the gut microbiome, and factors that we're exposed to in the environment. They could be toxic chemicals. The Western diet is also thought to play a great part. So, in clinic, this comes up quite a bit. Sometimes patients may ask me, well, why did I develop this? Is there anything that I could have done differently? And the short answer to the question is, you did nothing wrong. There was this genetic predisposition and something in the environment brought it out. And so it could be a genetic mutation, which is the picture on the left there, kind of trying to depict a gene mutation. There are particular genes that are associated with autoimmunity. These are called human leukocyte antigen, or HLA. They're located on chromosome 6. So you can have an aberrancy there. So GWAS stands for Genome-Wide Association Studies. And so you may have heard of all this genomic sequencing that's going on. So through this, we've actually learned about these non-HLA genes that may play a part in autoimmunity. There is one to watch. It's called PTPN22. And that particular gene in the future may be addressing multiple autoimmune diseases. So we're not there yet, but perhaps down the road, we may be able to have one gene that can explain multiple autoimmune conditions. So there's this genetic predisposition and an epigenetic phenomena from, say, the environment, right? And so smoking is an example of this. When an individual is exposed to tobacco, there may be this chemical change that occurs in the gene. So it doesn't change the sequence, but it's kind of a chemical reaction, if you will, in the gene that then affects the immune system. And this ultimately culminates in the autoimmune disorder. So other factors may also contribute to autoimmune disease. It is increased in first-degree relatives, especially higher in identical twins. Ethnicity plays a big part. It differs between different geographical regions. I'll give you an example. There is a condition called Takayasu arthritis. It's quite prevalent in young women of Asian descent. Usually the cutoff age is 40, so less than 40. And many of these females are Japanese, but Asians in general may be predisposed. Age. So there is an entire specialty in pediatric rheumatology. And so any age is fair game. There are babies that get these diseases. In fact, I spent a month during my training at Children's Hospital in Los Angeles, and the youngest child that I had that had rheumatoid arthritis, so juvenile rheumatoid arthritis, if you're affected as a child, was 2 years old. So the entire age spectrum is fair game, all the way up to 100 plus. Now, just to let you know that there are characteristic ages of onset. By the way, Dr. Gamboa and I will be cross-referencing each other quite a bit through the course of this talk. I'll be talking to you about lupus, and this is typically a disease of childbearing age. So gender plays a big part. Again, a picture's worth 1,000 words. So let me show you kind of in a bar graph, really the risk of autoimmunity in females versus males. And so in some of these diseases, it might not be very, very clear, but on the left is Sjogren's syndrome, which is a condition that causes a lot of dryness in the eyes and the mouth. I'll show you a picture in a little bit, but almost exclusively in women. Many of these diseases, lupus also is very prevalent in women as well. It doesn't mean that men can't develop them. They do, but at a much lower rate. Now, having said that, sometimes we find that when men do develop these diseases, their symptoms are much more severe. Changes in the gut microbiome also have been thought to play a role in autoimmunity. And not only the initial onset of the disease, but progression as well. And so what is thought to occur is that due to inflammation in the intestines, there is this translocation of gut bacteria into the various different organs, causing inflammation and damage in those organs. So the prevalence of autoimmunity is about 3 to 5% worldwide. So that equates roughly to about 50 million Americans, according to the American Autoimmune Related Disease Association. In the same individual, sometimes you can have multiple autoimmune conditions. The most common autoimmune diseases are diabetes and thyroid disease. These are managed by endocrinology. They're not rheumatology diseases. But just to give you an idea, this figure is supposed to depict that, if you have one autoimmune condition, you're actually at risk for having 2 or 3, other autoimmune diseases as well. So this is a little fun fact. This list actually came from a T-shirt that I received from the American College of Rheumatology years ago. And so, it kind of makes its appearance in our household every now and again. My husband, of all people, is the one that wears this T-shirt. And I think to this day, he's still trying to, keep track of all the different diseases we treat. But these are not all rheumatic, by the way. So many of these we treat as rheumatologists. Others are non-rheumatic, and so we will refer out to the appropriate specialties. And so I just kind of wanted to give you an idea that there are many, many autoimmune diseases. Actually, to be quite honest with you, there have been several more that have been just identified in the last 2-3 years. So this list is ever growing. So this is just to give you an idea that autoimmunity can affect any organ, head to toe. We have autoimmune diseases of the eyes, the heart, the skin, you name it. Many of the diseases, even within our specialty, we can either co-manage, or we actually, if they have other organ involvement, the kidneys or the lungs or the skin, will end up working with the other specialist to figure out, what is the right treatment that will perhaps address all these various different organs. And in other situations, we may discern, okay, this patient doesn't have a rheumatic disease, and then refer out to the appropriate specialty. Myasthenia gravis or multiple sclerosis, these are neurological autoimmune diseases, so they will be managed by neurology. So what are some signs of immune system dysfunction? Well, it's going to vary based on the disease, but some of the common symptoms are joint pain and swelling, characteristic rashes. So we learn kind of a pattern recognition, if you will. We look for certain lupus rashes, for example, may have a certain pattern. Butterfly rash or dermatomyositis may have this what's called a heliotrope rash, where they look like they have eyeshadow on their eyes. They get rashes on their knuckles. They get rash on their chest and on their back. So patients have these kind of characteristic rashes that go along with the different disease processes. I'll show you pictures in a little while. Oftentimes, there's a recurring fever. Why? Because of systemic inflammation. The first thing we do when we encounter these patients with what they call fever of unknown origin, because usually the fever has been there for many weeks to months. So we want to rule out infection, and we try to rule out malignancy or cancer before we say, okay, this is autoimmune. They may have swelling of the glands, again, due to, these glands being revved up, the antibodies kind of being revved up. And again, ruling out infection and malignancy. Usually there's evidence of systemic inflammation. And so some of the markers we check are called sedimentation rate, C-reactive protein. And we see that these are quite elevated in some of these autoimmune diseases. And finally, immune activation. We see elevation in immunoglobulin levels. So I just wanted to give you a little kind of peek into some of the diseases. And so I'll just go over clinical manifestations of a few select autoimmune diseases. This is not going to be in depth by any means, but just wanted to introduce you. So this is Wegener's granulomatosis. It's a disease that's called a vasculitis, where patients have inflammation of the small blood vessels. They usually have pretty significant skin involvement. They have inflammation in their eyes. The bridge of the nose may be affected. They oftentimes have lung, where they get cavitary lesions, or they may have hemorrhaging from their lungs. This is it's associated with high mortality, and usually, these are very, very sick patients. They can develop kidney involvement as well, and sometimes the kidney disease can lead to kidney failure and dialysis. The age range is just really vast. My youngest patient with Wegener's was in his early 20s. So, these are diseases that can affect young people as well. So Sjogren's syndrome that I talked about earlier on is a disease that causes extreme dryness in the mouth and the eyes. Patients don't make saliva or tears. They cry, there are no tears. The mouth is so dry that they get lots of cavities. There's a high risk of lymphoma in these patients. So oftentimes when we encounter them, we're trying to downregulate their inflammation to decrease the risk of lymphoma. Scleroderma is a disease that affects collagen structures in the skin and the internal organs. As you can see, you're seeing children in a lot of these pictures now, and so children can get this too. It can be very debilitating, as you can imagine. The gut can be involved, so they have a hard time eating or swallowing. They develop Raynaud's. It's pretty characteristic of scleroderma. Well, we see it in some of our other diseases as well. They develop vasospasming of the blood vessels, and sometimes those blood vessels can become, the digits can become ischemic and even gangrenous. So this can also be rather serious. Dermatomyositis is a disease of muscle breakdown, and they get a lot of skin involvement as well. Children also can develop this disease, as you can see on the bottom left there. And oftentimes when we see these diseases in children, they're actually much more sick even than the adults. So how do we make a diagnosis? Well, Dr. Gamboa, you may agree that sometimes we feel like the little guy on the right there, right? We're trying to put these clues together and put the pieces of the puzzle, together. And so we rely on a good history and physical exam. And with this history, we're looking for clinical symptoms. We're looking for clues as to whether or not the patient has the disease that we think they have. And we're looking at blood tests. We're looking at antibodies to support the diagnosis. Now, rheumatologists order a lot of blood tests. And why? Because there's a differential diagnosis. There's a couple of diseases we're thinking of. And so we're trying to kind of rule these out. There's usually a pretest probability, when we're ordering these blood tests. We typically don't do a shotgun approach, but yet there's still quite a bit of blood tests involved. Imaging. So we may rely on x-rays, ultrasound, MRI, CAT scan, all of these to, again, help put the pieces of this puzzle together. Biopsies are oftentimes necessary, not only to make the diagnosis, but also to risk stratify patients, and to give us a sense of, say, for example, lupus nephritis, how serious is it? How sick are they? And what kind of treatment are they going to need? So finally, we look at criteria, and these criteria are vetted and developed by the American College of Rheumatology and the European Alliance of Association for Rheumatology. They just changed their name. And so these are very stringent criteria, updated very regularly. And in a moment, I'll show you kind of a snapshot of what one of these clinical criteria look like. But putting together, clinical symptoms as well as imaging and those other modalities that I just discussed. So we get this situation sometimes where, patients have rashes and all these crazy symptoms and the blood work is normal. And so we're really then having to go to biopsy or imaging to try to, put this together. So this is an example of one of the classification criteria that I was just talking to you about. This was just recently released from the American College of Rheumatology. And this particular one is for giant cell arteritis, which is a disease that affects older patients. They develop inflammation of the temporal vessels or the extracranial vessels of the aorta. It is a medical emergency. Patients, if they're not treated, they can develop blindness. And so we're looking for, all these various criteria and get points. And so if you have a certain number of points, then there's a high likelihood that this is, what we're dealing with. Biopsy, again, here is the gold standard, and we try to obtain this whenever possible to help make the diagnosis. So treatment is really aimed at resetting the immune system. That's a really hard thing to do. I'll show you a slide in a little while, but usually the immune system has just gone awry. It's just wreaking havoc. And we're kind of trying to reel it back in. And so sometimes patients will ask me, well, can I just do this with diet and exercise? And unfortunately, because the immune system is so active, we do need the meds to kind of calm things down. The diet and exercise is really important, and as I will show you in a little while, but that alone isn't going to fix the problem. And so, the treatment ultimately is aimed at resetting the immune system. So this is a busy slide, but I kind of wanted to give you a snapshot as to what may be happening. These two diseases, Dr. Gamboa will discuss in a few minutes, but as you can see, there are many different cytokines. These are proteins that are released by the various cells that I showed you earlier. And so these guys are upregulated. And in a lot of ways, we're basically trying to figure out, okay, which one of these cytokines is upregulated, and this is going to be our target for treatment. The immune system is very tricky, and so sometimes patients may be responding to one drug and then they stop responding, and then another cytokine is upregulated. So we're almost trying to figure out how to outsmart the immune system. So ultimately, what we're trying to accomplish with treatment is kind of tipping the balance in favor of decreasing inflammation. So, certain cytokines may be upregulated in these disease processes, and we're targeting those with the medications and the lifestyle modification to kind of bring that seesaw back into balance. There are many medicines in development and others that have been FDA approved for the various diseases. know that there isn't one treatment for all of it, because these cytokine profiles are so different. So, and I tell my patients, if you are going to have rheumatoid or psoriatic or lupus, now's the day and age to have it, because we have such good treatment options, and the outcomes are much, much better than they were historically. So there are many different treatments, biologics, that are available for the various different diseases. So lifestyle modification, as I mentioned earlier, works alongside meds. This is very important, and there's no downplaying it. So this is some fascinating data that has been released recently on the Mediterranean diet and its impacts on reducing inflammation. And so, many of the anti-inflammatory diets do help. If you're plant-based or vegan or vegetarian, that's all good. The most compelling data that has been released, even by the American College of Rheumatology, has been about these Mediterranean diets. And so the whole idea is that, they do appear to decrease inflammation, improve gut homeostasis, and also help with weight control. So ultimately, what is a Mediterranean diet? Mediterranean diet is high in vegetables and fruit, and chicken, fish, low in carbs, low in saturated fats, and refined sugars, and no red meat. Okay, exercise. So exercise is very important. It's been shown to counteract exacerbated inflammation in several experimental and clinical conditions. So you're seeing these cells come up over and over again on these slides, just to show you that exercise also has an effect on these cytokines and decreasing inflammation. Not to mention that when you exercise, you release endorphins that help with pain and mood and lots of things. So exercise is just so good for you. We have, these interesting discussions about exercise in clinic. And so at the end of the day, what is now recommended is 30 minutes, 6 days a week. Both aerobic and resistance training have been shown to improve physical capacity, muscle function, and even, several clinical symptoms of many of these rheumatic diseases. So this slide probably depicts this even further. So exercise does decrease pro-inflammatory cytokines, or has been shown to decrease pro-inflammatory cytokines, maybe have an effect on local and systemic inflammation, and thereby perhaps have an effect on systemic damage, and has been shown to improve or decrease the risk of disability. So the other thing that's important in autoimmunity is vitamin D. And I'm sure that, many of you are aware of this. So vitamin D has been shown to play a role in autoimmunity when the levels are low, especially. And what appears to happen is that low vitamin D does affect the microbiome of the gut, the homeostasis of the gut. So there's that intestinal inflammation, back to that slide I showed you some time ago. And so due to this kind of breach of the barrier, there's bacterial translocation, which can occur, and then these can affect organs and cause damage. Anecdotally speaking, I can attest to this. I have many patients, either when they are first diagnosed with their autoimmune condition, or when they have a flare, we find that their vitamin D is very, very low. Just to give you a frame of reference, the range is 30 to 100. So we're targeting around 40. We don't need patients at the toxic levels, right? I don't really push to get it that high, but if we get it around 40, we're happy. Usually when the autoimmune disease is really active, we see it's in the single digits. So we're really trying to get the vitamin D levels up while we're working on their other treatments as well. So this was actually a very interesting study that was it was actually published in the New England Journal of Medicine 2022 for osteoporosis. And the whole premise was looking at vitamin D for osteoporosis. It didn't pan out. It was rather disappointing where osteoporosis was concerned, but where it did pan out was for autoimmunity. And so they actually looked at vitamin D and omega-3 as decreasing the incidence, the cumulative incidence of autoimmune disease And so I don't have a pointer to show you, but the red and the green bars are showing decreased incidence of autoimmunity in individuals that were taking vitamin D. So in the study, they were taking 2,000 international units of vitamin D, as well as 100 milligrams of omega-3. So conclusion of this study was supplementation for 5 years with vitamin D3 and or omega-3 reduced autoimmune disease by 25 to 30% in older adults compared to those who took neither supplement. The effect of vitamin D3 appeared stronger after 2 years of supplementation. So take-home points in closing: over 100 autoimmune diseases. These are not all rheumatic. Presentation may be variable. There's a genetic component as well as environmental factors that predispose individuals. Treatment depends on the disease, and we can all work towards basically having a healthy immune system by exercising, eating a healthy diet, and perhaps taking a vitamin D3 supplement. And with that, I'll stop. Thank you so much for your attention. I'll be back with you in a few minutes.
Thank you very much for that relatively comprehensive introduction. Appreciate it. One thought that came to mind when you were talking, though, is that you're often not working in a vacuum, I think, if you're a rheumatologist, because since autoimmune diseases, especially, for instance, can affect any organ system, what I see is a lot of collaboration going on. And that's one of the great things that's happening in medicine, is that physicians of different disciplines are coming together, not just with the diagnosis, but with the treatment. So a child with some autoimmune disease may have a rheumatologist involved, may have a pulmonologist involved, may have a dermatologist involved, and everybody's working together on this. So because of the complexity of it, and especially in terms of where do you go with treatment? I have the liberty of being able to insert my questions because I'm the moderator. So do you take supplemental vitamin D?
I do, actually. Yes.
Yeah, I think it's almost impossible to get up to a level of 40 or 50 without taking supplemental vitamin D. Again, if you've got more color in your skin, if you have more melanin pigment, it's harder to produce the vitamin D in your skin. So definitely the more sun exposure you get, obviously, the better for vitamin D. But I think it's almost impossible to get typically to the levels that we need without taking supplements. So there's my plug for supplements. I'm next going to introduce Dr. Joe Gamboa. Joe is a native Cerritos and went to UCLA for his Bachelor of Science, and then went to Loma Linda. Where did we hear this before? For his medical school. Now, he went to Huntington Memorial for his residency in internal medicine, but then came back and did rheumatology again at Loma Linda. So sounds to me like that's a hotbed of rheumatology here in Los Angeles, which I didn't realize. So Joe is got multiple publications. He's done multiple research presentations, and as I mentioned earlier with Dilrukshie, I'm very pleased to see that he's also multiple side gigs going on. Now, you play the violin and piano. I wonder, do you ever get together where she plays the guitar and you? But also too is a big exerciser, and there's no question that, especially as I was saying before, if you're trying to reduce stress, you need to be taking a look at multiple ways of doing that. So with Dr. Gamboa, it's basketball, running, and hiking. Again, high aerobic type activities that get your heart rate going and reduce your inflammatory level, right? Your inflammatory burden. So anyway, without further ado, Dr. Gamboa.
All right, thank you so much for having me. So I am going to go over 3 rheumatological autoimmune diseases. So I'll first speak about rheumatoid arthritis. Then afterwards, we will talk about psoriatic arthritis. And then finally, we will talk about systemic lupus erythematosus. So first, we'll talk about rheumatoid arthritis. Well, what is rheumatoid arthritis? Well, to sum it up, it is an autoimmune disease. A simple way to look at it is the immune system is attacking the joints. And when the immune system is attacking the joints, it creates inflammation of those joints. Specifically, if we want to get really specific, it's attacking the synovium, which is a part of the joints that allows for certain movement. And the synovium has parts to it. It has a capsule. It has a fluid and different parts. So the immune system is specifically attacking that. So in rheumatoid arthritis, immune system attacking the joints and it's causing inflammation is how we can look at it. And what is the epidemiology of rheumatoid arthritis? Well, it affects all races worldwide. It can affect females more than males, like Dr. Cooray alluded to, in a 2-to-1 ratio. In adults, now there is pediatric rheumatoid arthritis, but in adults, it can usually affect women 40 to 60 years old, and in men over 50 years old. And the prevalence is about 1% of United States adults. So in this slide, the reason I put this is kind of give us an overview of autoimmunity. So inside the joints, there's an imbalance of the immune system. The immune system has been turned on for whatever reason. We've mentioned genetics, we've mentioned some exposures, and it is sending signals to the body to cause inflammation of the joints. And with that, with the inflammation, it can cause some damage, which we will talk about. But this is just a quick overview slide first. So what happens when the immune system attacks the joints and causes inflammation? Well, it can cause erosions of those joints in the synovial area. Then it can lead to some joint deformities as well. And if this inflammation of the joints is not put in check or not stopped, the inflammation can also spread to other parts of the body, including the heart, the lungs, the kidney, and the skin. So inflammation does play an important role in rheumatoid arthritis. So this is a picture to show how rheumatoid arthritis can affect the lungs. Again, it attacks the joints, but if it's not kept in check, it can go to the lungs as well and can cause some nodules of the lungs. So what are some of the risk factors for rheumatoid arthritis? So we really can't say, oh, this one thing that causes rheumatoid arthritis. However, it's believed to be an interaction between genetics and the environment. Genetics based on the immune system and whatnot, what Dr. Cooray has mentioned, as well as environmental factors that was also mentioned earlier. Things like smoking and infection can play a role as well. And then gender, just like we mentioned, women are at more risk of rheumatoid arthritis than men. So when the immune system is attacking the joints and causing inflammation, what are some of the symptoms of rheumatoid arthritis? Well, usually you get joint pain and swelling on both sides of the body, that's bilaterally. And rheumatoid arthritis really likes to affect the knuckles, that part of the body, both sides. So that's a big or classical presentation of rheumatoid arthritis. However, you still can get some joint pain and swelling of the wrists, as well as the knees, ankles, and toes. And with that joint pain and swelling, there could also be associated joint stiffness, as well as stiffness, most notably in the morning, that lasts for more than 1 hour. So just remember, in rheumatoid arthritis, it's both sides of the body, and classically it likes the knuckles. So here are pictures of rheumatoid arthritis affecting the knuckles. Rheumatoid arthritis can also affect the joint next to the knuckle. It's called the proximal interphalangeal joint, or PIP for short. It really doesn't affect the joint in the fingers that's closest to the nail. That's called the distal interphalangeal joint. So the left picture shows how the knuckles are affected, as well as the right picture as well on both sides, or both hands. And here was our first picture, which shows, again, knuckle involvement. And then if there's chronic inflammation of the knuckles, the knuckles can lose its structure and cause some deviations of the fingers, or it deviates outward away from the thumb. That's called ulnar deviations. And that's later on, as we'll go over the stages as well of rheumatoid arthritis. So it can also affect the toes as well, which we mentioned, and here are pictures of that. It can also affect the elbow, as seen on the left picture, and it can also affect the wrist. This is an X-ray, one way that we can see evidence of rheumatoid arthritis, where there's been destruction of the wrist bones, as well as the forearm bones, the ulnar and the radius. So how do we diagnose rheumatoid arthritis? And Dr. Cooray mentioned it as well. We're kind of like detectives. So first and foremost, we get a good history. We try to listen to which joints are affected. For how long? Is it both sides of the body? Is it associated with any morning stiffness, joint stiffness, swelling, things like that? Then we do a physical exam to see which joints are swollen, which joints are red, which joints are affected. We can also check specialized lab tests, which also mentioned as well. We check the inflammatory markers. Dr. Cooray mentioned the sedimentation rate and the C-reactive protein, which are inflammatory markers. And rheumatoid arthritis, like we said, has some inflammation involved, so we can see that as well. And then there's certain antibodies that are playing a role in rheumatoid arthritis. One is called a cyclic citrullonated peptide, or CCP for short. That can play a role, specific for rheumatoid arthritis. And not as specific, but could possibly play a role, is rheumatoid factor as well. And then lastly, X-rays. We can see which joints using X-rays are affected, which have the erosions, as we mentioned in rheumatoid arthritis, which are not affected as well. So we put that all together and we see if it fits the clinical presentation of rheumatoid arthritis. So here are stages of rheumatoid arthritis, which we mentioned earlier. On the very left are stage 1, which isn't very developed with the rheumatoid arthritis, but if the inflammation is not put in check, like we said, it can gradually or speedily cause some destruction of the joints. So the bottom pictures are X-rays of the hand in the beginning stages, and then over time, if the rheumatoid arthritis is not treated, it loses its structure of the knuckles, and then there's deviations in the later stages. And here's another picture and X-ray of even later stages of rheumatoid arthritis. And again, we see later stages of rheumatoid arthritis. We see the deviations from the knuckles and deviating outward away from the thumbs. So with that knowledge that we have about rheumatoid arthritis, that helps us with our treatment. So again, we're going back to the slide. In the joints, there is an activation of autoimmunity, meaning that the immune system sees ourselves, or our joints in this case, as a target. And when it does that, it releases certain, we'll call them messengers, that are upregulated, and this causes inflammation. So knowing this, our treatment kind of is tailored towards this scenario. First and foremost, we mentioned what happens if you don't treat the inflammation. There's more destruction. It can go to other parts of the body, which we do not like. Thus, the first step we do is try to stop the inflammation as quickly as we can. And we're able to do this with something called steroids, which is good and bad. It's good because it can stop the inflammation pretty quickly. However, it's bad because it's not really a long-term treatment or long-term solution. Long-term use of steroids can cause things like osteoporosis, weight gain, high blood pressure, diabetes, to name a few things. So we really don't want that to occur. But we know that first and foremost, we need to stop the inflammation so it doesn't progress to any later stages. So that's a short-term treatment, but the long-term treatment is to try to help the immune system set it back into balance. And like Dr. Cooray said, there's certain things that are upregulated, downregulated. So we're trying to focus on that. So that's what the bottom slide is the bottom picture is trying to show. We have medications that try to help with the whole scenario of the immune system, sending signals which cause inflammation. And these are things that we call immunomodulators because it tries to help modulate the immune system. And the medications can play a role in certain areas of that scenario. For example, one thing that gets upregulated with inflammation is something called tumor necrosis factor, or TNF, and we'll mention some medications that try to help with that. So what are some examples of rheumatoid arthritis meds? Well, we'll put it into two categories. The first category is called disease-modifying anti-rheumatic drugs, or DMARDs. So these are medications such as hydroxychloroquine or Plaquenil, methotrexate, and leflunomide or Arava. So again, trying to reset, or balance out the immune system. Then we have things called biologics. See, these are considered a little bit stronger and focusing on some of the upregulated inflammatory messengers, as we will call them. So these are medications like Enbrel or etanercept, adalimumab or Humira. These try to stop the TNF, or the tumor necrosis factor, that's upregulated with the inflammation that we mentioned. There's also other medications like tofacitinib or Xeljanz, baricitinib or Olumiant, uptadacititinib, Rinvoq, Orencia, abatacept, and rituximab/Rituxan. Just so you've heard of them and can have an idea of this is how the arsenal or toolbox that us as rheumatologists use to try to help the immune system and keep the rheumatoid arthritis from progressing. So what about rheumatoid arthritis and exercise? Well, I won't dive too much into this, but there are ongoing studies about it. First and foremost, we don't know directly how exercise can affect rheumatoid arthritis. We have an idea, but not directly, and more studies are being done. But what is good news is that exercise does help with the aerobic capacity, as well as endurance and strength in adults with rheumatoid arthritis. And in the studies, each individual was different. They underwent physical therapy to tailor their needs, but at the end, there was a lot of improvement in that regards. So that's it with rheumatoid arthritis. The next thing we will talk about is psoriatic arthritis. So what is psoriatic arthritis? Well, to put it plainly, it's an inflammatory musculoskeletal disease that's associated with psoriasis. And psoriasis in and of itself is an autoimmune disease where we could think of it as the immune system's attacking the skin. And it causes a skin lesion, and that could be described like a plaque, and it's kind of silvery as well. Most of the time, dermatologists are able to help out and treat with that. But as rheumatologists, we can focus on the arthritis part, because in psoriatic arthritis, not only could we think of it as the immune system attacking the skin, but it's also attacking the joints as well. But there's some distinctions between psoriatic arthritis and rheumatoid arthritis that we'll get into as well. So here's the picture of psoriasis. It usually likes to affect the extensor surfaces of the body. So that's the parts of the body where you could extend, such as the elbows and the knees, but it can generally affect the whole body, essentially. So what is the epidemiology of psoriatic arthritis? It can affect females and males equally, and it can occur in about 6 out of every 100,000 patients per year. So what are some of the clinical manifestations of psoriatic arthritis? Again, we have the psoriasis, and then we're going to look at the arthritis part of the joint part. So we also get joint pain and swelling of the peripheral joints. So these are the joints that are furthest away from the midline, or think of the heart as the center. So it's away from it, such as the hands, such as the feet. However, in psoriatic arthritis, unlike rheumatoid arthritis, it really doesn't classically affect the knuckles. Rather, it likes the middle joint, the proximal interphalangeal joint, and then the distal joint that is closest to the nails. That's called the DIP for short. So that's a distinction that you could put in between to distinct it between rheumatoid arthritis and psoriatic arthritis. And there could also be associated with psoriasis some nail pitting as well. And then also in psoriatic arthritis, you can have some pain and swelling in the areas where the tendons or ligaments attach to the bone. So for this example on the picture, it's showing the right Achilles tendon, which attaches to the heel bone, is inflamed and swollen. So that also can happen in psoriatic arthritis. And what are ways that we can diagnose psoriatic arthritis? So kind of the same way that we diagnose rheumatoid arthritis, we try to get a good history, try to see, okay, is there any rash involved with the joint pain? Which joints are involved? Is it associated with anything else? With the physical exam, we can check to see if there's psoriasis involved. Which joints are affected? Is there pitting of the nails? Are the tendons inflamed as well? And then we could also use specialized lab tests to confirm what we are thinking. So again, we also check inflammatory markers, the sedimentation rate, and C-reactive protein. We can see if there's any rheumatoid arthritis labs or if those are negative as well. And then there's also antibodies involved. Dr. Cooray mentioned the human leukocyte antigen. There's one called an HLA-B27 that can be associated. And then we have X-rays as well to confirm our suspicion. So on the picture, we have the X-ray of psoriatic arthritis. We see in the actual hand, there's some psoriasis involved, but in the X-rays, it shows that the knuckles aren't the ones mostly involved. Rather, it's the middle joint, the proximal interphalangeal joint, as well as the distal interphalangeal joint. So that helps us out as well. And using all those things together, we can come up with a diagnosis of psoriatic arthritis. So the treatment for psoriatic arthritis, similar to rheumatoid arthritis, but I wanted to show what's going on in both the joints, that's the left part of the picture, as well as the skin, the right part of the picture. So it's an autoimmune disease. The cells or the immune system cells are upregulated and sending off certain signals, causing inflammation of the joints and or the skin as well. And there's certain signals that are upregulated that our treatments look for. One is called an interleukin 17, one is called an interleukin 23, which some of the medications we have try to focus on that. But for the short term, again, we try to stop the inflammation as quickly as possible with either steroids, or when it's skin involved, we can try creams as well. But for the long term, because we don't want steroids for the long term, we mentioned that earlier, we look at immunomodulators again, and we'll see some familiar names as well. So we have the disease-modifying anti-rheumatic drugs again. In this case, it's methotrexate and leflunomide or Areva. And for the biologics, we again have some similar names, the medications that stop tumor necrosis factor, Enbrel, etanercept, or adalimumab Humira. But there's medications we mentioned, the IL or interleukin 17. So secukinumab, Cosentyx tries to help with that. The interleukin 23, Stelara or ustekinumab tries to help with that. And then there's other medications, abatacept, Orencia, or apremilast, Otezla. So again, we're trying to use these medications to reset the body's immune system, to balance them out so it's not causing issues with the skin and the joints in psoriatic arthritis. So we'll touch on the last subject, systemic lupus erythematosus. So what is systemic lupus erythematosus, also known as lupus or SLE for short? Well, it's defined as a chronic autoimmune disease with an unknown cause, very broad. But we try to put it down or try to specify it. So technically in systemic lupus erythematosus, it can affect any organ of the body, and it can cause inflammation of any organ of the body as well. And we'll go over the criteria for that, but just keep that in mind. So the fact that it can affect almost any organ of the body also means that it can resemble a lot of the diseases, a lot of the autoimmune diseases that also occur, such as rheumatoid arthritis with the joints and so forth. So it can resemble an autoimmune disease, it can resemble an infection or an infectious disease, and it could also resemble a hematological or blood disease because blood is involved, which is part of the criteria as well. So the American College of Rheumatology that Dr. Cooray mentioned earlier does have criteria for this. And there are 11 criteria for lupus. We want to meet 4 out of 11 criteria to meet the criteria for lupus. So first and foremost is the malar rash or butterfly rash on the face, photosensitivity. There's a discoid rash, which I'll show, oral ulcers, which are usually painless in lupus. Interesting there. Arthritis, which we kind of mentioned, and it's again of the peripheral joints, and 2 or more, and with evidence of some swelling, tenderness, and so forth. Then there's something called serositis. So that's inflammation of the lining of the organs, specifically of the lungs. So that's pleuritis, where the pleura around the lung is inflamed, and that can cause pleuritic chest pain with breathing, deep breathing, as well as fluid around the lining of the lungs, as well as pericarditis, inflammation of the lining around the heart, which can be seen on an EKG, as well as fluid around the lining of the heart as well. So these are the pictures that show a malar rash or butterfly rash on the face. So that's the picture on the very left. It can be distinguished from other facial rashes, such as rosacea, in that in the middle picture, it spares the area in between the nose and the mouth called the nasolabial folds. Just one way to try to distinguish it. And on the very right is the photosensitivity. That is a severe reaction to light, even a limited amount of light, where you get a severe reaction from it. So these are criteria for lupus. Here are discoid rash is the picture on the very left. It can occur on the face. It kind of looks like a marble type of rash with some dark edges. So it's a very distinct type of rash. And then the oral ulcers, which are usually painless, are seen there on the right picture. The story that patients often tell is that they're brushing their teeth and they notice that there's an ulcer in their mouth and they take their toothbrush to stab it and it doesn't do anything, doesn't hurt. And then arthritis, again, inflammation, tenderness, and swelling of the peripheral joints. Here's an example of lupus arthritis affecting the hands. However, unlike rheumatoid arthritis, classically, lupus arthritis doesn't cause erosions that we mentioned earlier. So again, a little bit of clue if you're trying to distinguish between the both. And then the pleural effusions. So on the left, the picture on the left shows that on the lungs, there's fluid at the bottom of the left lung. And on the right picture shows fluid around the heart called a pericardial effusion, making it look really big. So we'll continue with the criteria. So part of the criteria is also kidney involvement called lupus nephritis, neurological disorders, seizures, and psychosis. So hematological disorders or blood disorders. So one is a hemolytic anemia where there's destruction of the red blood cells, as well as low white blood cells, low lymphocytes, and low platelets as well. So you can kind of see how it can be, lupus can resemble a lot of different diseases because different organs are involved. And lastly, the lab results. So each one gets a point. One is called an anti-nuclear antibody, or ANA. It's usually very high in lupus, as well as some positive lupus-specific lab tests, such as a double-stranded DNA, an anti-Smith, and an anti-phospholipid antibody. So again, trying to get 4 out of these 11 criteria to diagnose lupus. And what is the epidemiology of lupus? Well, it can affect all races, and it can also affect one case for every 100,000 patients, females more than males. And it can occur in a younger age, around 16. Again, there's also pediatric lupus, but it can go up to 55 years old as well. So what is the pathogenesis of lupus? Again, we don't know it entirely. However, based on the research and the studies that we've done, the thought is that it has to do with the antibodies, and the antibodies are causing some immune complexes to clump together, and these immune complexes can deposit into certain organs. On the picture on the right is a staining for these immune complexes in the kidney. So that's kind of how we know that. And in doing such, it can cause inflammation of the kidney, damage of the kidney, and also continue to tell the immune system to keep going as well. So that's the thought of what can be going on in lupus. And again, this disease doesn't have to just be in the kidney. It can be in other parts of the body. So depending on the characteristic of the antibody, it can upregulate some immune complexes that can deposit into certain cells, such as a skin cell, getting the rash on the face, a joint cell, the arthritis, and then the kidney, and that can cause the lupus-like symptoms. So risk factors for lupus. So we felt that there's some genetic factors, which we've mentioned. A lot of genes are being looked at for lupus. And then the immune factors, which we mentioned, the autoantibodies, the immune complexes. And then lastly, the environmental factors. Cigarette smoking is a risk factor for lupus. So again, the treatment, we've kind of touched on this already, how to treat it. On the slide on the right, again, the environmental factors, the genes cause an imbalance of the immune system, causing increased immune cells to cause signaling that can then affect the skin, the kidney, and if this chronic inflammation occurs, it can cause some damage. So a lot of the medications try to tailor this. So the first and foremost, we try to stop the inflammation with steroids again. But for the long term, we also use immunomodulators such as hydroxychloroquine, Plaquenil, azathioprine or Imuran, or Benlysta. So Benlysta tries to focus on the part of the slide kind of in the middle that shows the B cell turning on the autoantibodies. So it tries to focus on that in order to balance out what's going on in lupus and hopefully stop the chronic inflammation. And then lastly, I'll touch on lupus and exercise. So wanted to say that the studies show that exercise is safe in lupus. We don't know directly what it does to lupus. More studies are being done for that, but it has helped with both fatigue, depression, and the physical fitness in patients with lupus. So it does play a role, and a good role, in lupus as well. And with that, these are my references, and I'll finish off. Thank you.
Before we get into the question period, I just want to say we got a very lovely comment from Judy Tobias, who is thanking everyone for honoring her husband, Stanley Tobias. Her comment was, he was a man dedicated to his profession and to his patients, and was so proud to be a member of Torrance Memorial family, and would have been very grateful for your kind words. So thank you again for that. I had a question. In your clinical practice, in terms of the various types of arthritis, Doctor, well, either one of you can answer this. What do you think is happening in terms of the incidence of some of these autoimmune diseases, like, for instance, rheumatoid arthritis? Do you think it's more common or less common than, say, 10 years ago or 15 years ago?
Well, that's a funny question to ask because since we specialize on it, that's kind of all we see. So we do see a lot of it.
Right.
It's hard to say if there's more so. It can fluctuate. There's some instances where there's more rheumatoid arthritis patients coming in, some instances not, but maybe it'll tick more towards a little bit more. But of course, like we were saying, there are a lot of medications and treatments that can help it. So that's always a good thing as well.
Well, I'd like to add, I probably have time on my side. I've been practicing for a little bit longer. And so I would say that there's been an uptick, and I do believe that it is environmentally mediated. Smoking has a lot to do with it. And we see this. And so, this is, I am always trying to encourage my patients to quit smoking, but this is another reason. And we do find that when patients are smoking, their rheumatoid arthritis stays active no matter what we do. But yeah, smoking is just one of the factors. But I would say that I do believe that there is a higher incidence of rheumatoid arthritis and psoriatic arthritis. It could also be that we've become much more sophisticated in identifying these patients early on. Many of our primary care doctors, kudos to them, are very good at identifying these patients and referring them to us, much sooner. So I would agree. It's on the rise.
Just an observation, especially certain hours of TV, you seem to be getting blitzed with these direct-to-consumer ads. And I wonder, too, if that doesn't heighten people's awareness that they may have this particular problem and they should then be checking into it. But whenever you talk about smoking, I wonder about air pollution. Do you think that is similar in some ways to smoking?
I'll take that since I talked about all the environmental stuff. I do. And I think also recently it's been on the news, with all the compounds and the plastics and so forth that has been correlated with developing autoimmune diseases as well. So yes, I do believe that air pollution does play a part also.
And you had talked about vitamin D as a factor. Do you think that there's any role for any other supplements, either in the prevention or in the treatment phase? I'm not thinking, again, curative and such. I think we need to be very clear. There's plenty of less than ethical advertising that's going on with supplements. Yeah. But what I'm wondering is, is there ethical value to some of the other supplements in some of these autoimmune diseases?
Would you like to take it? Okay. So I have looked at this because this, comes up quite a bit in clinic. I don't think we have very strong data to support taking multiple supplements. One of the things that often comes up in clinic, and I'm going to just address it right here, is probiotics. And the problem with probiotics is that there are so many different compounds out there, so many substances out there, and the data just hasn't caught up. And so we don't really have strong evidence to advocate for them. So we encourage patients, to get it from their diet. And same goes for the other supplements as best as possible, to try to obtain those by eating a well-rounded, healthy diet.
Can we cycle back to the beginning of the questions? There we go. There was a question on exercise. If 30 minutes 6 times a week is recommended, is 60 minutes 3 times a week just as good?
I don't know that I've looked at that directly, but I would say yes.
Okay. It's interesting. I'm a big fan of aerobic as well as strength training and such. Came across an interesting small study in a cardiology journal talking about as you age, whether or not you should be doing high intensity interval training. the vigorous exercise. And what it showed was that higher calcium scores in the very extreme exercisers, which suggests that maybe as we get a little bit older, we should cool it. I think the evidence is pretty good that exercise is good, and it doesn't necessarily have to be vigorous, violent. You don't have to be running up and down the stairs, of the local football field to be getting a benefit. Walking, especially walking your dog, because you should have a dog, is an excellent form of exercise. So if rheumatoid arthritis reaches stage 4, can the hand be rebuilt?
So that's, again, another hard question to answer. Technically not. However, there are advances in orthopedics and in hands that can try to help with that, definitely. But directly, there's no way to reverse the damage that has been done. It has already been done. But again, with our colleagues in orthopedics and plastics, they have a lot of advances in their technology. They may have an answer to that, but the direct answer is there's no treatment that reverses it once it's gotten that bad.
So I had a question. You showed us a vast array of drugs, and you mentioned that especially the immunomodulators are targeted against certain chemicals. How do you go about choosing an immunomodulator?
That's a great question. So the other thing I didn't mention is that there are also a lot of side effects with the immunomodulators. So we also use that to tailor our treatment as well as there's certain diseases, comorbidities, thank you, that can also be associated with certain diseases like COPD and whatnot. So we kind of put it all together, and then we try to come up with a good solution, because we just don't want to add something and exacerbate something else or cause another issue elsewhere. So we kind of look at it as a whole. I was just focusing on it in relation to rheumatoid arthritis, obviously, at that time. But we put it as a whole, and we learn about the patient as a whole to find out the best treatment that we can.
Yeah, and that's well put. And I think we're also in the age of what we call precision medicine, where we can actually tailor the medicine to our patients, and that's really important. We can have a sense that these diseases have upregulation of certain cytokines, and for example, tumor necrosis alpha in rheumatoid arthritis is a common target to start off with. And so this becomes very nuanced because the immune system is so sophisticated. So sometimes patients may respond beautifully, and then they have, they stop responding. So that's called efficacy failure. So then we're trying to figure out, okay, well, which other cytokine is now upregulated, and trying to go after that. So a lot of it, the wave of the future, let me say, is pharmacogenomics, right? Where, by gene testing, we can discern which cytokine is upregulated and go after that. We're not there yet. So to Dr. Gamboa's point, a lot of it is, trying to figure out which is the medicine that the patient is comfortable with, looking at their other comorbidities, and then choosing a treatment this way.
Yeah, the complexity is phenomenal in terms, and the exponential increase in the amount of information we're getting about these is really, hopefully artificial intelligence will help us to try and sort out some of these questions.
Yeah.
We have a couple of questions on arthritis. One of them is besides the autoimmune types of arthritis, is there such a thing as good old arthritis?
So the answer is yes. It's actually way more common than autoimmune arthritis. So this is the arthritis that is due to wear and tear, overuse. Our joints over time do and can wear out. So that is called osteoarthritis, and it can affect almost any joint that we use: the hands, the knees, the hips, and so forth. So when people say good old arthritis, due to the fact that it's the most common, we go with osteoarthritis, which is, as we get older, we can overuse our joints.
Although it's interesting, I've been interested in bicycling for many years, and it doesn't seem that there's a significant increase in osteoarthritis in cyclists in the knees. And yet you would think that years and years of cycling could potentially wear out your joints. So obviously there's some sort of a middle position here where use is good, overuse is probably bad. And overuse, as we all know, can be because you're carrying excess weight. And so I think it's very key. Plus the inflammatory component of fat and the effect on the system too, which is.
Yeah, that's huge. And that's, another thing that we really try to get a handle on in clinic. So weight is inflammatory. And at the end of the day, I realize it's so nuanced. Some patients really have a difficult time losing weight, try as they may. But even in osteoarthritis, there is data to suggest that it is weight that drives inflammation. So osteoarthritis is not an inflammatory arthritis per se. The medicines we use for rheumatoid arthritis or psoriatic arthritis, do not apply, right? But one thought is that, even losing just, 10% of your body weight equates to 50% improvement in pain symptoms, which can be huge.
Did we cover all the ones in the beginning?
Yes.
Cool. We did. Okay, so good. Another question came up about the gut microbiome. Is it useful to refer patients to a nutritionist or a dietitian in autoimmune disease?
So, I actually think there is value in doing that, and that may be my personal opinion. But, patients, and this is anecdotal data, but patients will tell me there are certain foods that they eat, they just don't feel good. And so, hopefully there may come a time when we may be able to identify these different gut bacteria or pathogens, if you will, and then try to, get a balance on those. But I think it's often very helpful to get input from a nutritionist if you're able to.
Yeah, I get a little bit worried, when we talk about people being on multiple drugs, and yet you're going to be taking something like a living organism,
Right.
which is much more complex than a drug,
Right.
or maybe 100 different types of living organisms. I think it's fascinating because people with different diseases have different compositions of their microbiome, and they tend to come in patterns. But the question always is it cause or effect? Is the disease causing the change in the microbiome, or is the microbiome contributing to the disease? And I don't think we're there yet. So I would suggest that people be very cautious about altering their gut flora in ways other than eating healthy, because that's the natural. You want to feed the bugs, right? You want to feed them good food. Does chemotherapy affect the immune system the same way as autoimmunity?
That's a really interesting question. So I may have to answer this another way. Chemotherapy can reset the immune system to a certain degree, but some of the new medicines, the immunomodulators that are out to treat cancer, actually have been associated with autoimmunity. And so we have seen either new onset of autoimmune conditions or exacerbations of previously controlled autoimmune diseases. So the bottom line is chemotherapy can kind of reset the immune system depending on what it is. And so can some of these new immunomodulators.
Yeah, it seems to me that you're caught with the immune system because you want to have immune surveillance going on in your system so that any little stray cancer cells get picked up in gut and get eaten, so to speak. And if you dampen down the immune system, there is a risk of cancer developing. We know that at least when I listen to all the disclaimers for all of the immunomodulator drugs, almost always in there's something that this can increase your risk of cancer because it does change your immune system. Again, having experts like yourself who can balance and get to the right balance of dampening down the immune system without overshooting it, I think is absolutely key. What length of time do you consider short-term use of steroids?
Well, you want to use it as shortly as possible, again, because there's always, with any steroid, you can always run the risk of high blood pressure, a lot of the side effects. We try, the data always says to use the lowest dose that's effective, and each person or each patient is different, so there's no set time. But we always try to come up with a game plan to try to lower the steroids as quickly as possible, but still have the same efficacy or same effect in stopping the inflammation as we can. So we don't want it to be several years, obviously, but we also know that we also have to stop the inflammation because we don't want it to get to different stages as well. So we have to find that balance. There's no like set time. However, we do try to make it as short as possible if we're able to.
Yes, I've being of a certain age, have seen steroids used for almost everything, and seen the problems that develop. And yet when they're used correctly, they can be life-saving, but also too, the quality of life can just increase so dramatically if they're used properly. Did you want to talk about tapering? Just to mention briefly, because I think that sometimes people with medications have this idea that, oh, it's working, now I can stop it.
Yeah, so again, another part of steroids is that it can affect almost any part of your body. So we don't like to just abruptly stop it. We like to do what's called tapering, where it's a stepwise decrease. Another thing that steroids can do is it can stop your adrenal gland. And your adrenal gland helps make your own body's type of steroid. So when you're taking exogenous or steroids pills, you're stopping your adrenal gland from making its own steroids. But if you abruptly stop the steroid that you were taking, your adrenal gland can't really keep up. So that can lead to things like low blood pressure and so forth. So what we try to do is with a taper, we go down slowly so your body can acclimate. And we can also see how you do with lower doses rather than just abruptly stopping it. And things may get worse, or things can come back, especially with inflammation.
Yes, true. And just to add, so typically, if a patient has been on steroids for longer than 2 weeks, then they cannot stop abruptly. If they've been on it shorter than 2 weeks, then you can. Generally, what we tend to do also is when we're looking at a taper schedule to prevent the adrenal insufficiency, we taper about 10% per week. And that's kind of a safe gauge. Now, two things typically happen. We use steroids as a bridge because many of the medicines that we use take time to start working. They can take up to 3 months or so. And so we'll use prednisone as a bridge. And then when the patient has been loaded with the medication, then we start tapering. And so we're kind of watching for resurgence of symptoms, as Dr. Gamboa mentioned, but we're also watching for signs of adrenal insufficiency. This doesn't occur in everybody. There's the very small percentage of patients that develop the adrenal insufficiency, but when they develop it, it's not fun. So we are careful about, how we're tapering those steroids.
I think we're at the last question. It's rather a complicated one. I have excessive GAD65 autoimmune antibodies. I'm receiving monthly IVIG, IV immunoglobulin immunity, concentrated immunity infusions for my condition. Will there be a point when the infusions won't be needed?
Oh, I'm so sorry that you're dealing with that. So, I am not an expert in GAD or GVD, but IVIG generally is a fairly safe drug and is pretty effective and efficacious for its uses. So, the short answer to the question, I have seen patients on IVIG for years for some of our diseases and have done pretty well. So hopefully, there isn't that type of an efficacy failure with IVIG. It is a combination of different immunoglobulins. So I think the failure rate probably would be lower. This is my guess.
Thank you. I don't believe that we have any more questions. So I want to thank everyone who has been online and who has been listening to this. And hopefully, if you got something out of it, all of these are recorded and they're on the Miracle of Living website. You can just Google Miracle of Living and it'll take you to a page which has these various presentations. I think that, again, tonight was a superb presentation by our two guests, and I want to thank them for taking time from their schedule and educating all of us, especially myself, about autoimmune disease. And again, once more, I can't help but say thank you, Mary Ford, for putting these on. I think that you do a great service to the community for doing that. Well, thank you, Dr. Gamboa, and again, thank you, Dr. Cooray.